It is a true honor to join everyone at the symposium today. I'm Laura Kim, a head and neck surgeon, part of the Otolaryngology department at Houston Methodist. I will be discussing how head and neck surgery has and is evolving with the advancement of technology. I have no conflicts of interest other than my interest and enthusiasm for robotic-assisted surgery and technology to better serve our head and neck cancer patients. Today, I will be discussing transoral robotic surgery and virtual surgical planning. My true goal of today is to bring awareness, share my excitement, and ultimately stimulate ideas and collaboration in further enriching the field of head and neck surgery through the advancement of technology. First, we'll delve into the role of robotics in head and neck surgery. To a greater degree than many other surgical specialties, the barrier to advancement in otolaryngology has been the inability to directly examine and access the anatomy in a living patient. It is a field in which progress has been limited not by physiologic knowledge, but more so by the pace of technological advancement. As early as the 6th century BC, there are documents recording nasal examinations via nasal tubular speculums crafted from bamboo shoots. Since then, the field has been driven forward by pioneers who skillfully adapt new technologies to intricate anatomy of the ear, nose, throat, and neck. A light conductor introduced by Dr. Philip Bozzini, the father of endoscopy, is the first internally lit device used to inspect cavities of the human body. The head mirror by Dr. Hoffman and the Hopkins endoscopes are instruments that we are more familiar with. Fast forward many years, and the modern-day otolaryngologist is equipped with a range of tools, including the microscope for the otologist, endoscope for the rhinologist, laryngoscope for the laryngologist, and for the head and neck surgeon, the Da Vinci robot. One of the most dramatic transformations in the accessibility for the head and neck surgeon is in the recent development of Transoral Robotic Surgery, or TORS, for oropharyngeal tumor resection. Given the difficulties associated with accessibility, difficulties with airway management, and concern for hemorrhage, surgeries of the oropharynx have been slow to develop. Traditionally, tumors of the oropharynx have been resected via an open approach, which can be very invasive, as shown here with the mandibulotomy, which involves splitting the lower jaw to gain access. The first robotic system introduced was the Puma 560. In 1992, the Da Vinci surgical system was developed, and in 2000, it was approved by the FDA for performing head and neck oropharyngeal procedures. In the early 2000s, Dr. Weinstein and Dr. O'Malley successfully demonstrated how the Da Vinci surgical system can be used for oropharyngeal cancer resections. In 2009, the Da Vinci Xi surgical system was introduced, featuring improved dexterity and visualization for complex head and neck surgical procedures. In 2014, the single-port robotic system designed for transoral procedures received FDA approval. In robotic surgery, the surgeon's hands are physically separated from the patient, the robotic instruments engage with the patient's tissues, and the surgery is aided by a bedside surgical assistant. Surgery is performed in a virtual environment, allowing the surgeon to interact with the patient's anatomy with a novel perspective. Advantages of TORS compared to traditional open surgery in the head and neck include: 1. Improved visualization and access to otherwise difficult to access areas with enhanced detail. 2. Reduced surgical morbidity, such as in blood loss, and faster recovery times leading to shorter hospital stays. 3. Potential for improved functional outcomes exists, such as in speech and swallow. And 4, there's the potential for reducing treatment toxicity by avoiding or de-intensifying post-operative treatment, for example, with reduced radiation and chemotherapy. Patients with the most potential for deriving benefit from TORS is in those with oropharyngeal cancer. And within this group, the subtype that is driven by the human papillomavirus, a group of patients that is increasing in incidence. These patients have a favorable prognosis compared to the non-HPV-related oropharyngeal carcinoma. As such, there has been modifications to the American Joint Committee on Cancer Staging System. Recently published and ongoing trials are helping to define the role of transoral robotic surgery in oropharyngeal cancer. Evidence to date supports the use of surgery as a valuable tool in this group of patients by allowing to 1. Reduce the extent of surgery, 2. Avoid or reduce post-operative treatment with a lower radiotherapy dose and field, and 3. To avoid or reduce chemotherapy, all of which would reduce treatment-related morbidity for the patient. Standard treatment for head and neck squamous carcinomas was defined before the HPV era. This includes radiation treatment of 60 grays in the post-operative adjuvant setting and 70 grays in the definitive curative setting. Adjuvant platinum-based chemotherapy is recommended for patients with high-risk features. And patients that present with metastatic lymph nodes without an identified primary site would receive wide-field radiation to all potential primary subsites of the pharyngeal region. Needless to say, this is associated with short and long-term toxicity, including dysphagia, xerostomia, fibrosis, with a large impact on the patient's quality of life. This is an example of a patient who was able to avoid radiation treatment altogether and in turn minimize short and long-term radiation treatment effects such as dysphagia and fibrosis. This is an otherwise healthy 57-year-old male who had presented with an enlarging neck mass. Further workup revealed the diagnosis to be HPV-related squamous cell carcinoma, however, without the primary site identified. Treatment options for this patient included radiation, targeting all potential primary sites, or to proceed with the diagnostic and potentially therapeutic TORS with neck dissection to address the metastatic lymph nodes. He ultimately underwent a diagnostic and therapeutic TORS surgery. Through improved access and visualization, we were able to identify the primary site, which was less than half a centimeter, and resect the tumor from the base of tongue with clear margins. A neck dissection to address the metastatic lymph nodes were completed at the same time. Based on final pathology, he was able to avoid any adjuvant treatment. He was able to tolerate an oral diet postoperatively and was discharged home the next day. By week 1 following surgery, he was close to his baseline function in terms of speech and swallow. This patient's case demonstrates the value of TORS in low-risk HPV-related oropharyngeal squamous cell carcinoma. Even when patients are to undergo postoperative treatment, the use of TORS may help reduce treatment toxicity. There are multiple trials examining the use of TORS in early-stage disease to reduce treatment-related toxicity through de-intensification of adjuvant treatment. Not to go into too much detail, but we'll touch upon a key trial to demonstrate this point. ECOG 3311 is the largest trial of TORS and transoral surgery. Patients, after undergoing surgical treatment with TORS, were stratified into groups based on features found on pathology: low, intermediate, and high risk. Patients in the intermediate group, for whom the standard of treatment would have been 60 grays of radiation, were randomized into 2 arms, a standard treatment arm and a reduced radiation dosage group with 50 gray. The results showed that 3-year progression-free and overall survival were comparable between the standard radiation dose group and the reduced dose group. As such, de-escalated adjuvant radiation of 50 grays is now included as an option in the National Comprehensive Cancer Network guidelines for early-stage oropharyngeal cancer patients. Also, in comparing this trial to the outcomes in non-surgical trials of definitive radiation or definitive chemotherapy, the 3-year outcomes are comparable or better. In the intention to treat analysis, patients who received reduced dose radiation were statistically more likely to have stable to improved quality of life than patients who received the standard dose. A secondary analysis with modified barium swallow found significantly lower aspiration rates at 6 months in patients randomized to reduced dose radiation. There are ongoing efforts to study the role for de-intensification in post-operative treatment with the use of TORS. Further questions remain to be answered in how to best individualize the use of TORS and de-intensification of post-operative treatment. Also, data comparing long-term outcomes from treatment toxicity need to be elucidated. Ultimately, the ideal treatment for each patient must be determined by evaluating the data, individual factors, and through shared decision-making in a multidisciplinary setting. However, TORS has been proven to have potential in greatly improving the quality of life of our patients as they navigate their treatment journey. There are, however, areas for improvement. Current robotic systems may have limitations in terms of fine motor control and dexterity, which can be challenging for delicate head and neck anatomy. Robotic surgery often involves the loss of direct tactile feedback, making it more difficult for the surgeon to sense the tissue properties and apply the appropriate force, which may be especially relevant in tumor resection. The size and configuration of robot arms can also limit access to certain anatomic areas in the head and neck and may obstruct the surgeon's line of sight during surgery. Although a great improvement has been made with the advent of the single-port robot, exposure and setup often remain the most difficult part of the surgery. Setup and docking process for robotic systems can be time-consuming, which may impact the overall efficiency and workflow. Lastly, robotic surgical systems require significant initial investment and ongoing maintenance costs, which may limit their widespread adaptation, especially in resource-constrained healthcare settings. Future directions for improvement in robotic-assisted surgery may include 1. Continual development of more versatile, precise, and miniaturized head and neck surgical procedure, or miniature robotic system designed for head and neck surgical procedures. Incorporation of advanced haptic techniques to provide surgeons with enhanced sensory feedback, enabling more precise and dexterous manipulation of delicate tissues. Integration of real-time imaging modalities such as augmented reality or mixed reality could provide surgeons with enhanced visualization and guidance during complex procedures. Integration of artificial intelligence and machine learning algorithms may also assist surgeons with decision-making, task automation, and intraoperative optimization. Lastly, advancements in remote surgical capabilities may enable specialists to perform procedures from a distance, potentially improving access to specialized care. Now we will switch gears a little bit and next briefly touch upon the use of imaging and engineering platforms in virtual surgical planning for complex head and neck reconstructive surgery. Virtual surgical planning, or VSP, is a powerful tool for the head and neck reconstructive surgeon in complex reconstruction of bony anatomy. This is most widely used for patients with cancer involving the mandible and maxilla. It is a process of creating 3D digital models of the patient's anatomy and using it to plan and simulate the surgical procedure before the actual surgery. It is particularly useful for complex head and neck procedures such as reconstructive surgery, tumor resection, and craniofacial surgery. VSP can improve surgical outcomes, reduce operating time, and enhance the surgeon's ability to visualize the patient's anatomy and plan the procedure more accurately. VSP planning process starts with imaging data acquisition. We first obtain high-resolution imaging such as CT studies, which is oftentimes obtained as part of the cancer workup. Next, a specialized software is used to identify and segment various anatomical structures, allowing us to construct a 3D digital model of the patient's anatomy. This allows for better visualization and manipulation. The 3D models are then used to plan the surgery with predetermined cuts and strategic reconstructive planning. Intraoperatively, Cutting guides, customized plates, and models are used to increase precision and to reduce surgical time. That's a cutting guide and a customized plate and a model. This is a patient with osteosarcoma of the maxilla. We were able to proceed with virtual surgical planning and obtain cutting guides, customized plates for the complex reconstruction of his maxilla with a fibula-free tissue transfer surgery. This is the patient immediately postoperatively and 3 weeks postoperatively. Advantages with the use of VSP include: 1. Custom surgical guides can assist the surgeon in accurately executing the planned procedure, improving precision and consistency of the operation. 2. Planning the procedure a priori, surgeons can minimize the time spent in the operating room, leading to faster recovery times and reduced risk of complications. 3. Virtual 3D models can provide surgeons with a detailed, high-resolution view of the patient's anatomy, enabling them to better understand the surgical site and plan the procedure accordingly. Ultimately, the combination of meticulous planning and reduced operative time can lead to improved postoperative outcomes, such as faster recovery and better functional and aesthetic results. Other areas in which VSP may add value would be in soft tissue reconstructive surgeries. For example, in patients with tongue cancer, when a large volume of the tongue is resected, this is reconstructed with the soft tissue free flaps, such as from the forearm or the thigh, as shown in the pictures. Currently, the volume assessment and shaping of the transferred tissues is completed by the surgeon at the time of surgery. Although in most cases, and certainly with an experienced surgeon, the volume match is fair. However, in some situations, the patient requires second and sometimes third revisional surgical procedures. Virtual surgical planning may add value in these situations by improving accuracy of volume assessment to avoid additional surgeries for the patient. AI-assisted assessment could also be a potential area of development to further help with improving accuracy of soft tissue volume match. Another potential area of limitation in VSP for the head and neck cancer patient lies in tumor progression between planning and surgery. Rare, but in some instances, there may be tumor progression necessitating adjustments to the surgical plan. Again, in most situations, and especially in the hands of an experienced surgeon, this may not be a significantly limiting circumstance. However, it is certainly with increased complexity, longer operative times, and increased risk for complications. Intraoperative image integration with augmented reality platforms may allow for real-time adjustments in the surgical plan, which would greatly benefit the select number of patients with aggressive tumor progression. This concludes my discussion on transoral robotic surgery and virtual surgical planning. I hope that I was able to bring awareness, share my excitement, and ultimately stimulated some ideas and future collaboration in further enriching the field of head and neck surgery through technology. These are some of the references I used. And lastly, I would like to thank you for listening, the Bookout Center for inviting me today, and to my colleagues and friends at the Otolaryngology department at Houston Methodist.
Well, thank you. Some pretty good-looking pictures right before lunchtime there, just to finish it off. So, Matt, if you've got questions, jump in. I'm going to kick it off. So, you have your hand on two platforms, single port and the intuitive. And the XI. Do you use the XI?
So I had actually trained with the XI during residency, so I'm familiar with the setup and the use of it. Starting in fellowship, I became more acquainted and familiar with the single port robot. And I can tell everyone that the single port robot is by far the more advantageous in terms of the setup, the ease of the procedure as well. So I don't think I would ever be going back.
So in the previous session, we talked about surgical resident training. In ENT, otolaryngology, does everybody have to train a single port robot?
So the residents certainly do get experience with the single port robot during the OR cases. They're often the bedside surgical assistants during these cases. And actually not too long ago, we had a single port training session with the help of Intuitive, also with the Mighty Lab, where the residents came and we were able to go through models, learn how to set up the robot and apply it.
So when somebody finishes otolaryngology training, can they go out and do single port, or they need to do an incremental fellowship?
Most of the time the robot is used by a fellowship trained head and neck surgeon, and I don't think that would change in the near future, but perhaps with a more widespread use of the robot, maybe improved access to the robot, that is something that we may be seeing in the future.
You have a question?
I mean, I have a question, but I don't want to step on my own talk, but just to mention some of the advantages that you mentioned as far as the ablative procedure, do you find that you couple either insetting flaps with the robot, so you do your ablative procedure, and if you're doing your own reconstruction, you showed an ALT sort of insetting that with your single port robot. Have you done that? Do you find that that provides any other advantages, or is that just kind of for bells and whistles?
I have mixed feelings about it, but I do certainly think that it can be used. I have certainly used the single port robot for insetting of the flaps, and especially in the oropharynx where it's difficult to access. I don't think it is an absolute necessity, but I think it does help with the accuracy and maybe save some time with the inset of the robot, if we take away the time of bringing the robot in and out.
Fair enough.
Now I've heard about crazy things like going transaxillary to take the thyroid out.
Yes.
Is that real?
It is practiced by some surgeons in the United States. It is very popular in Asia, where there is a lot of stigma for scars across the neck, and where the patient population, of course, is a lot thinner, so it makes it easier. But it is used for thyroid surgery, even parotid surgery, where people will enter retroauricular behind the ear.
And is that the single port robot, or just the
with the single port robot?
Okay. Very interesting. So, is a single port more expensive than the XI? Do you know?
I think it is. I would have to look that up.
So we went out to Intuitive, actually, really exploring the vascular applications. And to be honest with you, prior to going there, I was thinking about intracavity procedures. And they suggested we try this cadaver using the single port robot. Transformational, because this really opens up extremities. And so we could dissect from the above the knee all the way up to the groin. We could turn it around and get in the popliteal fossa. We could put it in the arm, dissect the axillary vein up. And then the nice thing from our standpoint is the robot, unlike the XI, where these arms are in the way of bringing in a C-arm if we wanted to combine endovascular and robotics, the single port moves the robot completely out of the target field, and so we could integrate imaging into it too. So it was very interesting, and opened up something I'd never really even thought about.
That is amazing. I've never thought about it for use in the extremities, but fascinating.